Good morning once again. Is it afternoon now? Okay, good afternoon. So my name is Dr. KESHY. I'm a consultant family physician with CardioCare Hospital.
Good afternoon. How are you? Good afternoon, everybody. I know why you're tired. It's cardiovascular. Now we're going to something different, which is endocrinology, diabetes. My people are there, they know now, diabetes. And there won't be any boring ECG, EKG, APC. No, this is straight to what you're. My name is Dr. Nonso. I'm an endocrinologist and diabetologist. So today we'll be taking you on diabetes care. And with this senior consultant, you're going to go through the slides.
Okay, so I'm sure some of you are wondering why diabetes in a convention that is, or in a symposium that is talking about sudden cardiac death. But we all know, or we should know, that diabetes is one of those major, or one of the diseases that constitutes a major cardiovascular risk. So diabetes care, for some people, diabetes is their only risk factor, and they may eventually, or they are already at risk of sudden cardiac death if it is not well managed. And that is why it is very important that we address this in this symposium. We'll be going straight to the points. Dr. Nonso is here for the technical. He's going to go deep, and we're just going to try to keep it very relatable and simple, and give you practical steps that you can follow. Yes, and quite interactive. Yes. So we'll look at the diagnosis and definition of diabetes. We'll classify it. We'll understand the risk factors and clinical features, how we investigate people with diabetes, how we identify complications, how we treat, and how we follow up people with diabetes, and when to refer. So when does your care stop, and when should you hand over to Dr. Nonso and his people to continue? Okay. So I'll be running through some case presentations. We have a 42-year-old newly employed office executive. While undergoing routine office medical checkup, he was found to have a fasting plasma glucose of 9.0, and a BP of 110/80. There were no other presenting symptoms. He was otherwise stable. How will you make a diagnosis of diabetes in this patient? Okay. Yeah. So, how would you make a diagnosis of diabetes in this patient?
Options.
Repeat. Okay, a repeat fasting blood sugar, oral glucose tolerance test, glycosylated hemoglobin, all of the above, none of the above. So please, let's log in and answer.
IT, can they log in?
Yes, so, yeah, people are already answering. Someone says all of the above, repeat fasting plasma glucose.
Why are you going back now?
And so as more people answer, I think the percentages are just.
There's no incorrect answer. The only thing we came here to learn. So, I don't like this mic.
Okay. So all of the above is still carrying it. Closely followed by repeat fasting blood sugar. HbA1c is in this third. Nobody is going for OGTT.
Why?
Okay, so I think we're good. Let's move. Is there any additional history you would want to get from the patient? Yes, no, I don't know.
I hope you know the additional questions, but you see it in the presentation.
Okay, yes. Yes. Okay, so most people say yes. If you say I don't know. Okay, so what is diabetes? Dr. Nonso, what's diabetes?
Simply put, diabetes is simply an endocrine or metabolic dysfunction that affects carbohydrates, protein, and fat. Not only carbohydrates, protein, and fat, which patients present normally with hyperglycemia. It's as a result of absolute insulin deficiency or relative. When you say absolute, it means that insulin is not there at all from ab initio.
Yeah.
Now, relative means insulin is there, but it's not doing function. Now, what you mean by relative is this. If the body, for instance, needs 10 units of insulin to move 100 grams of glucose into the muscle, in resistance, it needs 20. So what does it mean? The body produces 10, but it needs 20. It means it cannot be able to move the 100 grams of glucose, meaning that you have hyperglycemia in the system. And all this must come with complications in the long run. Very simple.
Okay, so thank you very much, Dr. Nonso. So I hope that helps us with the diagnosis of diabetes. So let's just briefly speak about the epidemiology. It's found in every population in the world and in all regions, including the rural parts of low and middle income countries. So everywhere in Nigeria, there are diabetic patients, even in the villages. It's not just a disease of the affluent or high income societies. You find it everywhere. The number of people with diabetes is steadily rising, with the WHO estimating that there were 422 million adults with diabetes worldwide in 2014. That's a staggering number. The age-adjusted prevalence in adults rose from 4.7% in 1980 to 8.5% in 2014, the greatest rise in low and middle-income countries compared to high-income countries, and that's very important.
As you can see, the prevalence is increased. This is 2014 now. Now move by 2045, you see what it's like. So it's really a pandemic now. I wish the minister was here to also see what is happening, because we also need to do something about diabetes in Nigeria, most especially. It's so bad that out of every 10, 2 is diabetic, meaning out of every 5, 1 person. So if you count ourselves here, out of 5 of us, 1 might probably be diabetic. So,
okay. So how does diabetes result? So this is this shows the classification, the WHO classification of diabetes mellitus 2019, type 1, type 2, hyperglycemia first detected in pregnancy, and the hybrid forms, the other specific types, and the unclassified.
Okay. This classification is very good, because why I like it is, if you are a doctor, a nurse working anywhere, and a patient comes in, you don't understand the diabetes, please, you can make it unclassified. Nobody will query you. So now, that being said, type 1, as you all know, is what you call the insulin dependent. You used to call it, because there's total pancreatic dysfunction. There's no production of insulin at all. That's for type 1. Then for type 2, and it usually occurs at early ages. Then type 2 is the common one we have everywhere, that's inheritable from family. Family history is very, very important, and it is as a result of insulin resistance. But now it's a continuum. When it's insulin resistance, initially the insulin is not enough, the pancreas is overproducing to meet up the body's demand. Over time, the pancreas becomes exhausted and the patient becomes insulin dependent. So that's why that initial insulin dependent and non-dependent was removed, because type 2 DM patients, not well managed, will eventually become insulin dependent. Now you have the hybrid form. This hybrid form used to be called type 1.5 before. The slowly evolving mediated diabetes of adults, we call it LADA. It's like the type 1, but unfortunately, it's not easily detected, and patients don't come down with DKA. The hybrid have the ketosis-prone type 2, also known as flatbush diabetes. These patients are obese, they look like type 2, but now they have DKA commonly in them. Now, the other specific ones, monogenic diabetes, the MODI, the MODI, the defects in insulin action, all those reproductions, Rabin syndrome. This of exocrine pancreas, pancreatitis can give to diabetes. Then other endocrine disorders, growth hormone excess, steroid, cortisol excess, thyroid disease too, can also cause diabetes. Drug-induced, most of these drugs we give our patients, antihypertensives, steroids, creams we use, all those things produce some level of insulin resistance, giving us a type 4 diabetes from this classification. After that, you have the unclassified. If you are confused about a patient's diabetic state, you can simply classify it as unclassified. Nobody will query you. Now, the last one is hypoglycemia first in pregnancy. There are two types. Diabetes mellitus in pregnancy. This is when a patient is detected diabetic. We'll come to that though. Before 24 weeks of pregnancy. But gestational diabetes is, we never start though. This is not heart failure. So, gestational diabetes is from 24 weeks when you detect a patient having high blood glucose, and that's gestational diabetes. Please.
Okay, so the pathogenesis, I think we won't dwell too much on this because of time. For type 1, for type 2.
Yeah, for type 1 is just autoimmune, most times autoimmune, so you don't have a problem. Family history is out of it. But for type 2, for this presentation, type 2 is the commonest diabetic state we have around. So we have actually dwell some on this. Now, what is the major cause? Pathogenesis means genesis of the pathology. Now, what is the major cause? Genetic predisposition, family history. Family history is very, very, very important. Why I keep on saying this is, I give an analogy. Someone that has a family history of diabetes, father, mother, brother, is already tilting towards diabetes. And now, someone that doesn't have a family history might be diabetic. Now, there's something that's a catch to this. These things can skip generations in the sense that your own father, uncle, everybody has diabetes. Meanwhile, the grandparents might have diabetes. But now, when you have a family history of diabetes, please, someone needs to watch what person does in terms of lifestyle. Why I say this is, I tell my patients, if you have a family history of diabetes, it's like buying a Mercedes Benz and a Hilux pickup. I decide to carry firewood with it. Now, firewood is normal lifestyle. Eat, drink, take your sugar, take your ice cream, do everything, all firewood. Now, the Mercedes Benz is someone that has a family history of diabetes. Why are they? Hilux pickup, someone that has no family history. Now, it's not carrying firewood. In the next 3 months, the Mercedes must go down because it's not meant to carry that kind of thing. Now, the Hilux pickup obviously will last longer, but in 2-3 years, that Hilux pickup might also go down. So when you say it's not in my family, it's not my portion. You know, the Nigerian statement, not my portion, not my family. No, you'll be taking sugary things, no exercise, no breaking of sweat, no walking around. That is the Hilux pickup. You break down sometime.
Yeah, and it's very important because you find those patients who are unwilling to accept the diagnosis because it's not in their family as they think. Now, how many undiagnosed diabetics were there actually in that family? So it may be that they did not know that there was a family member. It may be that they didn't know that it's happening with them for the first time, but that does not mean that it's not important that each person be identified and managed appropriately.
Hold on, sorry. Now, this obesity and sedentary, this is a cause across all disease states, but diabetes only is the worst. The obesity is more of central abdominal obesity. That is our own problem. And now, sedentary lifestyle, we call it soft life now, whereby you move from your AC car, AC house, you don't even change this thing. Office, everything, the most control.
Back home.
You don't break one sweat. You are living the life, yes. My brother and sister.
How many of us are walking up to 5,000 steps a day? I'm just using 5,000. Can I see by show of hands? We're trying to. Okay, so, God is watching, though. Okay. So risk factors, we talked about family history of diabetes, a parent, a sibling with type 2 diabetes, obesity, once the body mass index is above 25 kilograms per meter square, habitual physical inactivity, of which a lot of us here are very guilty. And it's important because we counsel patients several times a day, and then you find that sometimes you are saying things that you do not do. Let each time that you counsel somebody on living a healthy lifestyle, an active lifestyle, be a reminder to you yourselves, because sometimes we're only thinking about our patients and forgetting that in this room, a lot of us have significant cardiovascular risk that we are not addressing. Okay? Race, ethnicity, African American, Hispanic American, Native Americans, previously identified impaired fasting glucose or impaired glucose tolerance. You want to say something about
yes,
that?
I want to, this particular part, I actually want to make a comment on that. Most patients I see, they will tell you that we are told that we have pre-diabetes. Now, without pre-diabetes, by the grace of God, diabetes is not. I'm a Christian, that's why I don't believe in God. Don't get me wrong. But it's time to separate common sense from what you call faith. So now, they come here and tell you that they're not diabetic. They say it's pre-diabetes. Doctor told me this and everything. Blood glucose at that point is 7.9, 8.1. And they were told it's around 8. So now, this person has a family, he's a father, mother, and he's not advised. Or rather, they will advise them, increase exercise, all these things. But that belief that he's not diabetic is what he believes in. You understand? Diabetic patients eat sugary things. Diabetic patient though. Now imagine someone that believes that he's not diabetic yet. You tell that person you're not diabetic, that nothing with lifestyle, everything will go back. That's the part I don't like. Go back. Now, from theory, by the time a patient presents with anything diabetic, that's in sugar, anything, the pancreas has gone down by some percentage. So now, how would that lifestyle modification take this patient back? I want you to understand when we tell patients this thing, or family relative, because when a relative calls you, brother, sister, am I actually diabetic? You want to help? Not really. You are borderline or pre-diabetes. With that, the patient becomes comfortable. But cancel this patient. Inevitably, if care is not taken, you will be diabetic.
Yeah.
So with that, there's a little bit of fear and awareness that comes in that lifestyle needs to be changed. And when you change this lifestyle, these things are what? Slowed down. Inevitably, it might develop or it might not come. But most times, it develops from what I have seen. So, in counseling our patients, please, we need to understand, because there are some points you need to go home with here. This diagnosis, how to manage this patient, treatment, and then follow up. That's the major aim here, so that you demystify this diabetes. So this pre-diabetes, know how you counsel your patient in telling them about, and tell them inevitably there must be a problem if care is not taken. Thank you.
Yes, and emphasize that they need to be followed up. So people who you have found impaired fasting glucose or impaired glucose tolerance in, you must emphasize that they shouldn't just go away and say, I am managing it with lifestyle, and then forget about coming back. So from time to time, they should have a check. They should have a fasting blood glucose check, a 2-hour postprandial glucose check, and a HbA1c. Okay, so history of GDM. So patients, another important thing is they will come in pregnancy. A few months after pregnancy, it has normalized and they disappear. Now, every woman who has had gestational diabetes is at risk of eventually being a type 2 diabetic patient. And so you cannot just let them go. If you are a gynecologist here, you're an obstetrician, when you are releasing those patients, always release them, discharge them to have an appointment with the physician, with the endocrinologist, to follow them up, because they are inevitably at risk of still becoming type 2 diabetics. So hypertension, high blood glucose, HDL cholesterol level, polycystic ovarian syndrome, or acanthosis nigricans.
Insulin resistance, that's no problem.
Okay. So the second case, a 38-year-old woman who presented in the emergency room with a history of weight loss, polydipsia, polyuria, generalized body weakness with blurring of vision and painful sensations on both feet. There's a positive family history of diabetes in both parents, of which the father died of diabetic complications. The random blood glucose on presentation was 26.9 millimoles per liter. Blood pressure was 160 over 100 millimeters of mercury. Is this patient diabetic? Okay.
So what's the difference between this one and the first one? Okay. Any volunteer? It's interactive, and nobody's marking you. There's no this thing. If you fail it, we tell you. I'll call name. No, anybody from KESHY, my answer, no talk. No before now. Anybody, just people shouted yes. Okay, let's go back to this thing.
Okay, go back to the previous slide.
Yeah. So now, in this second one now, there is, okay, yes, positive family history, blurring of vision, painful sensation, RBS of 26.9. But in the previous one, no presentation, just a fasting blood sugar of 9.0, which is above the normal. That's why I said, is that person, okay, that first one, was it diabetic?
Could have been.
Was it diabetic? No, there's no fear in this thing, yes or no? But the answer. Yes or no? No. I said no, I said yes, no. Actually, why I said no is, you don't make a diagnosis with just one fasting blood sugar without symptoms. We come to that. Yeah. You must have to tell that patient to go and come back. Then subsequent question, family history, complications to rule out in these patients. So, this one you are correct.
What type of diabetes is she more likely to have? Type 1, type 2, hybrid forms, unclassified, none of the above.
Why is it not unclassified? If you're confused, I said unclassified, we accept it. We're not going to find out what it is. Actually, it's type 2 from the family history we talked about, the age of presentation, and now coming in with complications. That's another thing I missed. Most times, these type 2 DM patients might... Okay, we are coming to that, sorry.
Okay. So what other investigations are important in the management of this patient?
Full blood count.
Abdominal CT, for focus on the pancreas.
Liver function test.
All of the above. Many others, but none of the above.
All of the above? Which above? Is it all or none? Let me know. All. I lie. Move.
Why would you want to do an abdominal CT scan on the pancreas?
To check the pancreas, know if it's still there, and maybe that's what they're thinking about. The
Why?
pancreas is still intact.
You have to use your patient's funds right wisely, yeah? Okay.
In this present, sorry, Minister, okay.
Okay. So what is your target blood pressure? Dr. Eze and Dr. Inua already mentioned that. What's your target blood pressure? Okay.
This correct answer,
yes,
it help for school.
What other possible complications can she have? We'll just run through because of time. Diabetic nephropathy, diabetic neuropathy, diabetic chorioarthropathy, directed retinopathy, I do not know.
They don't want to move.
Okay, so we'll come to all of that. How do we make a diagnosis of diabetes, Dr. Nonso?
Now, like we said, I made this very simple. Symptomatic patients means coming down with osmotic symptoms, polyuria, polydipsia, polyphagia, infections, weight loss, and you do a single fasting blood sugar greater than 7.0, it is diabetes. Now, patient comes in, polyuria, polydipsia, have you eaten food? Yes, I ate food 2 hours ago, no problem. Do an RBS, not 1 hour ago, from 2 hours. Do an RBS, and it is greater than 11.1. That patient is diabetic. Now, if you have a patient that, like we described, got to work, routine investigation, and now found 10.0. Any polyuria? No. Polydipsia? No. Family history? Doesn't know. Everything. Please, don't label him yet. Because if you label a patient diabetic, you must treat. And the patient must be on drug for life. It's not a matter of you take it for some time and you stop. Or maybe you go somewhere, they go and do something for you, and diabetes goes away. This is a thing I see on the internet. Patients send it to me, doctor, what do you feel about this? I don't open such things. What do you feel about this? And some people even used Obasanjo's voice, a big picture. That he drank this thing, he's no more diabetic. Someone I saw in conference 3 months ago, addressing us about his diabetes. Now, this AI is something. And they are selling, people are buying, the person bought and was telling me my take on it. My take. I didn't bill him for the call, but I bought nonsense. So, this asymptomatic patient goes home, come back. Now the question is, when will the patient come back? Is it the same day? Next week? Next 2 weeks? What do you feel? 1 month after? Why are people quiet now? There's no catch in this thing. Okay, make you put that money. If someone gets it, how much? Now, what you're going to do is, please, at that point, that person is not diabetic. Don't tell him stop eating sugar. Stop eating. Eat here, swallow apple, eat anything you want to eat. At that point, see us if it's convenient for you in 2 weeks' time. You hear what I said? So to allow him to go and marinate the food very, very well. And now check the pancreatic function. So now you have the other impaired, the one I talked about, the pre-diabetes, also talked about. Now, HbA1c is also used, but HbA1c is marred by so many flaws, you understand? So why basically you can see a patient with HbA1c of 11.1, fasting blood sugar 5, 2 hours postprandial 7.1, HbA1c 11. What would you do? You can start giving the metformin. So now, in such situations, that's why I didn't put it here. HbA1c has its problems. First of all, the technicality of this program, of the investigation. The range they are using is DCCT trial range. There's no universal range. That greater than 6.5 for all these things is a DCCT trial. They've not tried Nigeria or Africa. So we are using what the white man is using. No problem. Number 2, the biological implications. People, it's as a result of glycation of red blood cell. You understand? What they call this? A model reaction. So now, the red blood cell determines for you the lifestyle of red blood cell determines for you the test specificity and sensitivity. So now, in a sickle cell patient that has a low PCV, obviously it's going to be different. Someone that lost blood, going to be different. Someone that has heavy menorrhagia. These are things that you should consider in sending patients for HbA1c. Now, people's level of glycation of their red blood cell are different. So with that, it gives you another problem. Why you shouldn't rely on HbA1c most times. We see it every time. HbA1c 7.5, not fast. They are confused. Let me call the endocrinologist. But now I'm trying to make sure nobody will call me to make it clear. That HbA1c should be kept down. Use their fasting and 2 hours postprandial. And now there's no evidence of clinical correlation between the HbA1c and presentation. What you know is that a fall in one reduces cardiovascular risk. But we've not seen somebody, no actual reports. I'm saying it from endocrine point of view now, not a general point of view. Why we have problems with all this HbA1c and everything. But now it can be used to monitor progress of blood glucose. We're not saying that's good. But in diagnosis, please let us use the ones we can use.
Yes. Okay. So impaired glucose tolerance, impaired fasting glucose.
Yes, that's the pre-diabetes you're talking about now.
Yes. So
C-peptide, that's for type 1 DM patients.
Okay, so clinical presentations of diabetes. One, of course, it may be asymptomatic, very important. And you find that some people will come and they came to you just for maybe an annual physical, and the fasting blood glucose was one of the tests that was requested. Somebody brought his brother to the hospital and decided to do a few tests. Somebody said they stopped at an outreach, these outreaches in public places, and they checked their sugar and found it is very possible asymptomatic, number 1, presentation. Number 2, presenting with the classical symptoms, polyuria, polydipsia, and weight loss. Now, they may present with one, they may present with two, or with the whole triad. Immediately you see a patient with weight loss, chronic weight loss, or weight loss alone, even if they don't talk about the other, but of course the osmotic symptoms are very, very, very common. Dr. Nonso, you want to add something on here?
I've said it before,
okay,
yeah.
So overweight, type 1 lean, type 2 overweight, very key, a key differentiating factor.
But now, doesn't mean they don't have fat.
Doesn't mean, yes, you have a lot, even type 2, you find a lot of people who are type 2 and they are very slim, and probably they have a strong family history. They may come with the acute complications, DKA, HHS, they may come with chronic complications. So they may be coming to you for the first time with just neuropathic symptoms. I'm having this abnormal sensation, numbness in my fingers, numbness in my toes. I feel this burning sensation on my feet, and it has been going on for a while, and they don't have any of the other classical symptoms. Everybody who comes to you with those symptoms, please screen for diabetes. Then so they may come with the complications. They may come with other diseases like autoimmune diseases in type 1. They may come to you with history of chronic steroid use. Already you are thinking this patient is at risk of being diabetic, and so those things should prompt us to screen, and different combinations of the above. So the clinical history.
Simple. The symptoms they present with: family history, pregnancy, just what you've been talking about before, lifestyle, dieting, other endocrine. Now, always ask for complications. Paresthesia, claudication means when a patient is walking and is feeling pain on the calf here. And when it stops, the pain stops. It's the first sign of peripheral artery disease. Please, let's not miss it. Let's not go and give diclofenac, paracetamol, please. Always tell the patient to go and investigate. Or send people for investigation immediately, because next thing, the foot will now turn to brown, from there black, from there amputation, if you don't come to CardioCare. So, but now, visual disturbances, leg swelling, then paresthesia, you see, most of these patients, when they come and tell you that they traveled in the village and came back and there's something doing them for leg, please, it is not, like Chief said, matching something. That is what they have. It is diabetic neuropathy. And another thing is this diabetic foot ulcer. They call it one name in the village that they heal. It is diabetes ulcer. So when you see all these things, the first thing you have to do is to try and disabuse this person's mind. If you don't do it, he will leave you and go and meet Babalawo straight. That can convince her or him. If you don't do it, you go to one malam where you go confuse them. So you must always disabuse that they are thinking. Because when they go out in the public, they say, no, it's something much in the village that one person was taken to Abakaliki. And that's what I want to keep on hearing. Even doctors say, let's not go there. So...
Yes. Okay. So in your clinical history, you're looking for the classical symptoms. You're looking for a family history, looking for the pregnancy and delivery history, comorbidities. So important, especially autoimmune diseases, abnormal test results, lifestyle features. It's very important. Delve into the lifestyle history. Does this patient smoke? How much is their alcohol consumption? How is their lifestyle? Do they exercise? Are they sedentary? How much in a week? How many hours in a week, or how many minutes in a week of physical activity do they do? How is their diet? Okay, diet and nutrition, drug history, so particularly steroids. Don't forget that they may be coming with topical steroid use, chronic topical steroid use. It may just not be taking prednisolone or taking all of those oral drugs. Some people may be using steroid eye drops for a prolonged period, predisposing them.
Bleaching creams.
Yes, bleaching creams. Those are very common.
Particular sex, yeah. Bleaching cream.
Then triple action creams. There are people who just chronically, they have a little itch, they go and pick up those triple action creams and use, and those have high steroid content. Okay, so history suggestive of complications. History, other endocrine abnormalities. So history suggestive of complications, paresthesias, like we mentioned, claudications, chest pain, erectile dysfunction. Sorry.
Please, it's a very important complication you must deal with as a doctor. If you meet a male diabetic patient, do not forget to ask him about erectile dysfunction. These patients will choose to have an MI and die than this thing not working. I'm telling you out of experience, forget about laugh. Seriously, if you address that issue, my brother, you are the best doctor in this world for them. Forget about any other complication. You can have stroke, it's no problem. But that ED, please don't always forget. It's a big issue for us men. No, for us men. And not because you're a female doctor, you don't want to go there. No, you must go there. You must go there. Please, let's address it holistically. Because in the end, improved lifestyle is what we are aiming for these patients. Thank you.
Okay. Yes, so visual disturbances. So at your initial diagnosis, it's important for them to have an ophthalmologist look at their eyes, do an examination of the eyes, cardiac conditions, and so forth. Okay, so your standard diabetic exam.
It's simple. It's even explanatory. You look at the head, dehydration, air hunger, thrush, neck. Another thing you always look at is when you see a patient with this black rash on the nape of the neck. It's called acanthosis nigra. It's not diabetes, so it's insulin resistance. Yeah. And eventually it leads to diabetes. So, eventually it leads to diabetes. Eventually it leads to diabetes. Sorry. So, now with that, the skin vitiligo can occur with type 1. The lower limbs, the eyes, you must always check the eye. The axilla, you can also see it there. Now for the feet is very, very important in diabetic patients. Please check for ulcers, calluses, helomas, because the first problem is diabetic neuropathy. And this leg, most times, lose sensation. And these people can match on charcoal, hot charcoal, they will not know. We had a case in Port Harcourt then, he was carrying nail for 6 days. From the history, he went to a carpenter's shed. He didn't know. 6 days ago, there was nail on his leg. For 6 days, he didn't know until the son now saw it and brought him. And then it was late. But we tried our best to save what you can save. So foot care in diabetic patient is very, 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 very important. Very, very, very important, please. So.
Okay.
So it's the same thing.
Yeah, still talking about the standard examination. We're
now, basic investigations. Sorry.
Okay, yeah. So the basic investigations you should do, of course, the fasting blood glucose, which you would want to repeat. If it is diagnosis, at diagnosis, you want to have 2. If the patient is symptomatic, 1 with symptoms, 1 abnormal plasma, fasting plasma glucose with symptoms. HbA1c is important. The lipid profile. Please shed more light on lipid profile. Okay. Someone asked a question previously.
Yes, ECG is also important. They can have a silent MI. Microalbuminuria is very, very important because the diabetic state on the kidney is a hyper filtration state. So we actually need to take care of that. Now, for the lipid profile, it is very, very important. Cause across diabetes and other causes. But now, the question is, which lipid are we dealing with? We have 2 common forms, the cholesterol and the triglyceride. I hope you're following me. Now, the cholesterol, I'm not talking about lipids as a topic. I will try to gloss over it. Now, the cholesterol is now grouped into low density, high density, intermediate density. Now, the triglyceride, we have them with chylomicrons. Now, the difference now is triglyceride is more fatty acid. Fat is what they chop for food, fat. But cholesterol is more synthesized in the system. Now, triglyceride do not cause cardiac problems. So when they're saying lipids, some are good, some are bad. Now, triglycerides do not cause MI. Doesn't cause cardiac arrest, anything. Doesn't cause peripheral artery disease. What it causes is pancreatitis. You understand? But cholesterol on its own now, if you have severe hypertension and there's a shear in the vessel exposing some endothelial tissue, cholesterol will go there and attach. From there, it forms a needles. Things come around it. A lot of cytokines, VCAM and ACAM are released. And now what happens? It forms a thrombus. From there, it dislodges and now goes to form the heart problem, stroke, mesenteric infarction, acute renal injury. I don't know if what I'm saying is clear now. So let's not mistake when you say go and do lipid profile. We have a lipid profile. We have the LDL, we have the HDL. The one people call good cholesterol, that's the HDL. Why do you call it HDL? It's what we call reverse transport of cholesterol from the periphery down to the, what do you call it, to the liver. Why? If it's high, he say it's good because you have so many HDL to mop up the peripheral cholesterol. If it's low, he say no. He wants it to come up. The other one, total cholesterol, LDL, if it's high, he say no, he wants to bring it down because that's the one that will kill the person. That one actually kills the person. So now when you are managing this patient, you have to be specific. Am I dealing with LDL cholesterol? Am I dealing with triglyceride? They have different treatment. Just that all we know is statins. Atorvastatin. What are they again? All the statins you keep on giving. Rosuvastatin. But now, the question is, what are you actually targeting? Someone that has triglyceride of 200 and something, you are giving statins. You don't do anything. The only thing we believe that somehow for that one to have a problem, the cholesterol has already been involved too. So we don't have a problem with that one. So, but we're not dealing with lipid metabolism here. Let's not derail. I don't know if I answered your question. All right.
Okay. So, notice, please, it's written in capital here. It's an abomination to review a diabetic patient and treat only his sugar without checking his feet. So foot care, very, very important and should be an important part of your follow-up. Some people will come and it's just, you find that they've been coming consistently just for refills. Please, at every refill, make sure that you look at these important things for a diabetic patient. Check look at the feet, look out for complications. Ask, some of these complications are there. Particularly if you're a female doctor, in my practice, I find that if you don't volunteer, if you don't ask, sir, do you have any other problem? Do you have erectile issues? Then he will look and then say, oh, actually, he has had this problem for some time. And you're able to deal with those issues. They may not volunteer some of those things. Have you had abnormal sensations in your feet, in your palms? Do you have some of those things? You actually have to ask and make a note that you have asked in your follow-up, even if it is a routine follow-up. Then make sure that you educate your patient because education is very, very important part of management.
Pastor will collect your patient. Babalawo will collect your patient.
Yeah, because they take their time to educate their patients. They take their time to go deep. Even if what they are saying is wrong, even if half of what they are saying is not true.
Bible quotations, so they will leave you.
Yes. So we have just a few minutes to go. So the complications, of course, we know the acute complications, which are metabolic ones, the chronic complications, and then other complications. Acute DKA, diabetic ketoacidosis, which most of us are very familiar with, hyperosmolar hyperglycemic states, lactic acidosis, iatrogenic hypoglycemia. Okay, let's just run through them. Infections, of course, diabetic patients are at risk of infections of different sources, usually bacterial. Then the chronic complications, you have the microvascular and the macrovascular complications. Microvascular complications, retinopathy, nephropathy, and neuropathy. The macrovascular complications, stroke, peripheral vascular disease, coronary artery disease, and cardiomyopathies. Other complications, the skin complications, you have the non-infectious ones, necrobiosis, lipoidica, diabeticorum, diabetic dermopathy, infections, candida, mixed diabetic foot syndrome, the eye, cataracts, glaucomas, diabetic ophthalmoplegia, the bone and joints, Dupuytren's contractures, diabetic arthropathy, Charcot's joints, pregnancy-related complications, recurrent abortions, polyhydramnios, infertility, fetal complications, macrosomia, congenital malformations, hypoglycemia in the unborn, and of course that sudden infants, sudden IOFD, that is very common. Treatment principles and targets. So let's just run through this. A 60-year-old businesswoman, known diabetic for the past 15 years, not compliant medications, presenting with this picture. RBS 30 millimoles per liter, associated calf pain while walking, blurring of vision and burning sensation on the feet. On examination, dark coloration of the right big toe. Investigations show normal EUCR, urinalysis, 2 pluses of protein, deranged fasting lipid profile. What is the aim or principle of management of these patients? Which of the complications do you think the patient already has? What other investigations would you want to request in his management? Any intervention you want to do in the management of the food?
Can someone say something, please, in a hurry? Principle of management is simple now. Can you go back to the case? No, the case.
Okay.
It's very simple here. Non-diabetic for 15 years, non-compliant. The first thing, you must cancel this patient on compliance. That's the first thing first. If not, you are wasting your time. Number 2, blood glucose starting point is not controlled. You must control the blood glucose. Now, look out for the complications the patient has. Yeah. He has calf pain while walking, peripheral artery disease. He has blurring of vision, retinopathy. Burning sensation, neuropathy. That correction of food, that is advanced peripheral artery disease. EUC, normal, 2% of protein, this is microalbuminuria. Please investigate further or place this patient on ACI-ARB. The lipid profile, address it immediately. And second question, which complications? We have listed it now.
We have listed them
Simple.
already.
This management is not difficult. Not difficult at all. What kind of investigation you can do for this patient?
Yes.
Which one will you do?
Any investigations? What do you want to do?
Just first say anything.
Just list. Doppler, yes. Doppler, yes.
Of where? Of the head?
Lower limb Doppler, yes.
Okay.
X-ray, yes. Foot X-ray, yes. ECG, thank you.
Don't say it's not cardiology we do here. This is diabetes now.
Is he diabetic? Is he hypertensive as well?
No. We're not going there.
Yeah, it's not bad.
Which other one? It's what is there already. The profile is there. Any other one?
Okay. HbA1c. You already know this man wasn't well controlled, obviously. Okay, so any intervention in the management of the foot?
What do you do? Cut off the foot, Abby. That's the old practice now.
Yeah.
They say, has it demarcated? Yes, they come and call orthopedic. They'll come after 2 days. Is it demarcated? No, they'll go back again. Come after 1 week. Is it demarcated? Yes. Go and bring blood. This is old practice. Now we have interventions for this thing. If you have a patient with this thing, don't do anything. Send straight to CardioCare. We do peripheral angio there to save the leg. If you keep on wasting time, it will be going back. Next thing, the whole leg is gone and patient dies. So with all this intervention, these things are out of. There's no problem again for us. Not something they go and cut off the leg or demarcation, no. Orthopedic always wants to cut out something. But I beg, nobody is here. But the main thing is we can salvage these legs. Please.
Yes.
Always
use at
refer.
Least the amount of limb lost, we can at least reduce what is
for
lost.
us, diabetic foot is like ST elevation MIO. So they are saying MI. It's because people die from needle prick, toothpick. One woman that was trying akara wanted to put akara in basket. There was a something. She died from it because of mismanagement. They first of all took her to one place, they put it inside hydraulic. From hydraulic, one man gave him black something to put. By the time he came, the hand was gone. So this is really why you should start from here and know what to do.
Yeah. So treatment goals: prevent, delay, and/or minimize complications, reduce morbidity and mortality, alleviate symptoms, and blood glucose control. Comprehensive targets in the management of diabetes for fasting blood glucose less than 110 milligrams per DL, that's 6.0 millimoles per liter. Postprandial less than 200 milligrams per DL or less than 11.1. A1C less than 7.7%. HDLC for males, okay, greater than 40, females greater than 50.
Please, they can copy this thing. Move.
Okay.
There's a problem here. I said we should calm down, but we've not treated diabetes. So what are we doing here now?
Okay, so diabetic treatment principles, education and empowerment, very, very important. Very, very important. In fact, you may not be able to exhaust it in one sitting or in one consultation. And I need to pause and tell you that you need to start. First of all, tell the patient what is diabetes. This is why your symptoms are this way. This is why your body is metabolizing sugars wrong. This is what we will need to do. These are the components of your care, and we need you to be a part. If the patient does not feel like they're a part of management in diabetes, they are very likely to have adherence issues and problems eventually down the line and develop complications. So that education is very important. Then lifestyle and diet modification. You should refer every diabetic patient to see a nutritionist. It must be done. At diagnosis, you should, and then they should have follow-up as needed. Diet modification, pharmacological therapy, and then cardiovascular risk modification. So main goal is patient empowerment. So self-monitoring of blood glucose is very important. Emphasize that patients should have their glucometers.
If not, the patient should go home. Every patient that's diabetic under treatment must have a glucometer. If not, don't treat the patient. I'm telling you, don't manage. It's not expensive now. Don't manage. When we were in school, there was no glucometer. But now it's everywhere. So, and that self-monitoring gives the patients the right to be on top of the situation. I'm feeling somehow, she tells himself, it's hypo, I take glucose. Yeah. I'm feeling somehow, it's high, come to hospital. Very simple. But before someone collapses, you don't know what is wrong. You carry glucose and give first.
Yeah.
If it comes up, it's hypo. So you must have glucometer.
A glucometer. So recognizing and treating, you must counsel every patient you are starting on treatment on the symptoms and management of hypoglycemia at home, because it will likely happen in their normal settings. Foot care and footwear, what they should wear on their feet, how they should look, how they should check for foot injuries, and what to do when they have even the most minute looking issues with their feet. Adherence and follow-up, cooperation with physician in meeting goals, lifestyle adjustments. Okay, so we would need to rush through everything. This is a brief algorithm.
Move this one. There's no need. Just move. Yes, okay. Stop here. Without wasting time, let's don't take you straight how to manage diabetic patients. Understand? Algorithms, all these things, look at what you're going to do. If you are accosted, that means you are accosted by a diabetic patient that's confused. Sugar is this guy, doctor, please help me. Don't call endocrinologist. You can handle it. First thing first, after your history investigations, correct everything. Now check what the patient is on, the drug. The patient must be on metformin. Why I'm saying this is, it is a sensitizer. It enhances insulin function. The endogenous one, that is not enough, it can boost the effect. So you start with this. Now, unless there's contraindication, end-stage renal disease, you can always remove it. After that, you add a secretagogue. Commonly, we use glimepiride. Not Dianil. Not that olden drug, that's, I don't know how to call that drug. Dianil, after 2 years, it becomes insulin dependent. It's so bad, the drug. If a patient is on, please remove the drug. Yeah. Replaced with glimepiride. This one binds 9 times and associated 9 times. So the history of this hypoglycemia is reduced, and then pancreatic exhaustion is also reduced. After that, if it's not controlled, you move up. You can add DP4 inhibitor, vilagliptin, to your metformin. And or I don't like this issue of making glimepiride 4 milligram, 6 milligram. Please, there's no need for that. We have enough things to match the effect, give you a synergistic effect in managing this patient. So no need giving patient 6 milligram for what? There's no need for that. That's same too. You add this one, there must be a change. But then if there's no change, you keep on going up. You add your SGLT2 inhibitors, dapagliflozin and pagliflozin. Although cardiologists, they've taken our drug, it's originally our drug, but now it's part of the heart failure stuff. Heart failure treatment. But now, you must add these drugs. It's a game changer in the sense that it doesn't have anything to do with insulin at all. Just a renal glucose clearance, but it has some side effects. But it's good. After that, forget about specialists, you can do that one. Now, you have to insulinize the patient. If after all these things, the patient's glucose control is not achieved, what you need is to insulinize the patient. At this point now, if you don't have the mind to give insulin, you can send to the specialist. But if you have the mind, insulin is a very good drug. It does not do anything. But in Nigeria, insulin is the end of diabetes. That person is dead. Your insulin? Hi, my brother. Don't finish. That is what you see here. But unfortunately, it's the best drug. So after how many drugs should we introduce long-acting insulin? If the patient will accept insulin for the first time, start insulin. But the problem I'm giving this algorithm is that to convince somebody to use insulin in this Nigeria, it's very difficult. So very difficult. Unless 2 drugs, if you're at most 3, you should be adding Lantus. Unless the sugar is so bad now that he's seeing himself that he's having ED, he's having everything. I tell you, anything he go do. You now give another insulin, he start working. And tell the doctor, please, when am I stopping this insulin? Say stop now. If he stops it after 2 days, everything goes back. He will use it on his own. He won't bother you again. Understand? Or tell the patient, let's do it for 2 weeks. After 2 weeks, if it's not good, you stop. After 2 weeks, they will continue. That's the secret I'm telling you how to put the patient. After 2 weeks, they will continue. They won't go back. But try and convince them.
Yes.
But if it's still high, please refer to endocrinologist.
Yeah. So at that point, you should be referring. After you have done, by the time you are done with 2-3 drugs, you should be referring to a specialist. So thank you. We have exceeded our time. We won't be able to go through the rest of the case.
Wait, that's a case history. When we go back.
Okay. This one.
That miracle stuff. Please go back. I think we jumped it.
I think it was.
This is a case of a patient that came from a revival. What's happening now? Now you lock him. So this particular case is a patient came from. No, not this one. Go back. Back.
Okay.
Yes. I read for us.
A known diabetic for 20 years, not regular with medications. He says he only takes his medications when he notices excessive urination and tingling sensation on the feet. In recent times, he has had about 3 episodes of hypoglycemia in the past 2 weeks, which made him patient stop his drugs. The blood glucose has since been under control without medications. Patients attributed the improvement to the church revival program he attended 2 months ago. What do you think is happening here?
The pastor laid hands on him and he received. My people, what do you think? Thank you very much. Thank you so much. This is diabetic nephropathy manifesting a miracle. Seriously. This is what we see. They say that they have been healed and they go home and they don't take their drugs. At that point, the kidney is going down. What happens? That 10 units of insulin the body produces. I want to explain what happened there. That is what the body produces. That is not enough for the body to use. Due to the fact that it's cleared by the kidneys now. The kidney is no more functioning. That 10 unit remains there continuously. It's supposed to last, let's say, 6 hours to be cleared. It remains there for the next 3 days. It must be doing function continuously. Function continuously. If you not add tablet to it, the insulin comes out, augments it, have hypoglycemia. When you remove the drug, patient say, okay. After 2 months, they will carry cow and go and get Thanksgiving. Please, when the patient comes with this thing, always check renal function.
Yeah.
I'm not saying miracle does not happen, but you know where miracle happens, please. Therefore, pregnancy, for the O&G people, the diagnosis is here. Fasting, greater than 5.1, 1 hour 10 and 2 hours. But now this is from 24 weeks of pregnancy. Anything before that is pre-gestational diabetes. The approach is different, the complications are different. But due to time, this guy has been here since. He said I should come down. Although I want to talk more, but he said I should come down. I will oblige and come down.
Okay, so thank you very much.
Please, I need questions.
Round of applause for them, please.
I don't know if you understood or I asked questions. Which one?
A round of applause for them. Let them ask questions, so we'll answer them.
Somebody can come. Okay.
Okay, but now we'll be welcoming questions pertaining this lecture. At least we can take.
Please, that guy that asked that question, that last question, don't ask me anything. No. That one,
Tell us your name.
All right. Presenters, good afternoon, and well done for a very excellent and comprehensive presentation. My name is Hassan. I am from the Nursing Council. Please, I want to ask the presenters a question, but I want to coin a scenario because it's something that happened January 2019 to September 2019, about 8-9 months event. I'll be very brief. Sir, you have a non-diabetic client who is exercise and drug compliant for like 10 years. But unfortunately, he accidentally had his nail cut by this cut.
yes, those
Yeah.
ambulatory pedicure people, I mean.
Exactly.
I modified it. Now Malam where they call name, but ambulatory pedicure.
Yes. So for like 10 years, the client has had was compliant with almost the exercise, the drug, and the food prescription that he used to have.
Yes.
But unfortunately, in January, he had his nail cut by one of the people on one of the little fingers. So, and that was how the condition started. And that took the life of the man.
What I'm saying, needle prick, toothpick is an emergency for us. So what did you do for the patient?
That is all I want to ask you, sir.
What I will do?
Yes.
No, what did you do first now? I will not know how to correct you.
One, I'm not a health personnel. Like, I'm not a doctor, I'm not a nurse. So
nurse will not do anything?
No. The best I could do.
Okay, then nurse.
I'm not a nurse, I'm not a medical doctor.
Okay.
So, what do you think led to the death of this man?
No, wait first now, before I ask that question.
Yes.
What do you do for this? Did you refer the patient to see a doctor?
Yes.
Was he seeing a doctor?
Yes, he has been seeing the doctor.
Okay.
And immediately that happened, I think after a week, he realizes that is beyond just an ordinary cut. So he rushed to the hospital. He had his glucometer and all of that.
Yes.
And like I was saying, he was taking his oral drugs. So nothing to worry about at that time. But immediately after a week, he felt that he has to go to the hospital.
That's the problem. I say nothing to worry about. There's something very serious to worry about.
Yes.
Immediately he had that cut. It's an emergency.
Yes.
You understand?
So, sir, one.
I know your question. Don't worry.
Okay.
What I would have done.
There are two questions, sir.
Okay, what's the second one?
One, what do you think led to the death of this man?
No, me kill him. I'm sure you know. So, I'll tell you possibilities.
All right.
You are addressing me like saying, I mean.
Okay. Two, what recommendations, most important, would you make to health care institutions like teaching hospital, general hospital, to provide life-saving skills and continuous...
Minister didn't hear now answer this question. I mean, they asked this. That minister question me, so
okay.
Don't worry. You see, first of all, when you have such situations, please, the best thing to do for that patient is send him to a specialist. You understand? All this trying to manage, because you have three things there: blood glucose control, infection, then blood supply to that hand. If there's no blood supply, it will not heal. Infection is there, it will not heal. Glucose control not controlled, no, it can never heal. And anaerobes is our greatest problem. So now, we have how to follow these things. Antibiotics, glucose control, take patterns of the vessel and everything, patients do well. It's not magic. But now, when you don't know what to do, or you are doing the wrong thing, that's why I say, always refer a patient. Anybody, patient I see, with a small cut on the leg, I'm running around.
We admit self.
I'm telling you, I'm running around. I always say he wants to go home. Person must stay back. So not cutting unsterilized ambulatory, or whatever you call it again, Aboki, now cuts his hand. He now stays 1 week at home. I don't know if he tried any hydraulic.
Exactly.
That is they do.
Fuel.
Oil. Or fuel or engine oil. And now waste the whole vascularity in that place.
Sometimes they will develop tetanus. Some people did not die from it, they now die from tetanus. So from all the things they apply.
I don't know. Infection, obviously, but it's an avoidable death. Very, very avoidable.
It's very avoidable. So what we say is that one of the reasons we organize this, and you have many people from general hospitals, from different places here, is to teach these basic things. Take care of the glycemic control. Take care of the cardiovascular risk, cholesterol, blood pressure, all of that. Take care of the infection. Then take care of the blood supply. So what we do in the cath lab, and we've treated several of these kind of cases, is we try and revascularize. There are two ways to revascularize. One, there's no blood flow to that limb or hand. Last week, 2 weeks ago, Peter, 2 weeks ago, a lady came from up north. We had to amputate her hand to save her. She's barely 38, okay? But she had the symptoms and was moving around for 3 weeks. What should land to the hospital within 24 hours. So by then, there's already gangrene. So what we do in that case is that it depends on what it is. It could be acute limb ischemia. There's a clot that blocked it. We take our catheter inside, we extract the clot, or we infuse drugs to break up the clot. Blood flow restores, hand is saved, leg is saved. Take care of the sugar, take care of that, that is saved. Number 2, it could be atherosclerosis. The place has gradually narrowed and become hard. What we'll do, get a wire past the blockage, get a bloom, open it up, then get a stent, a small metal stent, and then put, so at the back, Medtronic, if they'll give us one stent, I can open it so that people can see. We'll put a stent inside that lesion and to keep it open and blood flow is restored. That wound will heal. Now, the third option is that surgical. You cannot go past it because that thing is completely blocked. There's nothing you can do about it. Then you do a bypass. You try and bypass the blockage with another vessel across the area, and then blood flow gets to it. And then the final option, patients already gangrenous, you need to save the life, quick amputation, antibiotics, sugar control, specialist care. But once a patient has developed a diabetic limb syndrome, lower extremity or upper extremity arterial disease, they need specialist care. They cannot be managed in any place without a specialist. Do not even think about it. The patient is most likely going to die, or you're going to lose the limb which you may have saved. Now, is this therapy cheap? No, it's definitely not cheap. That is why we are teaching the basic things. Everybody that comes to your clinic with diabetes, don't just change their drugs. Teach. Teaching is the first thing. And one of the first things you want to teach is food care. You want to teach sugar control, yes. You want to teach diet, yes. You want to teach exercise, but you want to teach food care. Some patients, some patient that came last week, a professor, I almost seized his slippers. Because I had told him, change this thing. The next time he came, he has no blood supply from here down. There's no blood supply. On this other side, we've already put a stent here and hardly blood supply. And he was still wearing one kind of slippers. You know, and that person, she told me, do I know that this is Bromley and Henley something that she bought in UK? I said, come on. Do you understand? So you cannot take it for granted. So when you are doing diabetes care, we take time to teach. The role of the nurse or the health educator is invaluable. So sometimes we finish clinic, we take out the patient, then we pass the patient to somebody else who just sits down to, what about your food? What about your leg? What about your eyesight? What about your performance in the bedroom? And take time to teach and show them what they can do to help all those things. That is the critical part of all of this. What killed the patient? Anything else, or his time has reached.